Okay, great. This is going to be a great introduction. As Claire said, I'm Nyalleng, and today I'm going to talk to you about documentation, which is, of course, the most interesting part of any process. And with that, of course, I joke. But I've actually started to get really keen on documentation, really interested in documentation. And I'm going to talk a little bit about why before I start talking about how our process of developing an equivalent of the data sheets documents, and we called it the health sheets. So this is work that we did last year while I was still at Google. So data sheets was this document, was this paper that was written a while back. Actually, one of the authors was Tim Nate, who's our director at DAIR, but also Meg Mitchell, who I think now is at Hugging Face. Anyway, so some of these people have been in ethical AI for quite a bit. But the purpose of this, they actually borrowed this idea from engineering, like hardware engineering. And the whole idea is you've got to document all of the pieces so that the work is reproducible. And it's a pretty easy idea, but it's really effective, and it was effective for us. And so now we're thinking about how can such a tool be adapted into health documentation. Claire, thank you for the lovely introduction. I don't have to go through this. I always give a little bit of a background. And the reason I give a bit of a background is because I think there is so much of us embedded in the work that we do. That's why I always put this, so that there is a bit of that context. Even in machine learning, where it's supposed to be active science, there's so much of us embedded in this work. This consortium, this group, this probably exists because of publications such as these about the harms of applications of machine learning, of artificial intelligence on health, about, of course, the study of health equity is old, because the history of it, the culture, all of the work that has happened before, all of the ways that societies have been arranged before have given us, health equities that we have now. And the way we are still arranged now is we still have these health equities, and they are not just from the data. The data just illuminates a little bit of it. The machine then ingests this data, and the machine then goes on either amplify or perpetuate this whole thing. And we try and we tinker with them, and we try to make them better, even though they are sitting on really problematic foundation anyway. But this is why we are here, and this is why we care, and we want to see how can we navigate through this. And so, like I said, why is documentation? This is more about me, about why is documentation so important. So I've been doing this work for a bit now. I've been doing machine learning or like data science for a little bit now. And at first, it was fun. At first, it was fun because it was about extracting pattern. And I actually started in genomics. It was about extracting pattern, was about, like just being illuminated and like, wow, by, oh my goodness, I figured this out from this data, or, oh, I made my robot move 5 steps, or I made a jump or something like that. And it was great fun. It was incredible that we could do these things. But now things have changed a bit, right? Because these systems have come out of labs and they've come to live with us. They've come into society and they're here now, and things have changed a little bit. And so other systems which start off which have a very strong technical, mathematical, scientific background, for example, healthcare, but for example, a discipline such as economics, right? You can have all the rigor you want, and it's beautiful, and you can get all these, projections and performances and all of this, and then you add people. And once you add people, the picture changes, right? Because people come with history, people come with culture, people come with power dynamics, they come with all of this, they come with fears, they come with emotions and preferences and all of this. And once you add all of that, then the picture looks quite different. And this has been what has been happening, right? We have left the world of like, hey, AI, play Tetris, right? And now we're saying, hello, AI, discover the latest drug for me, right? Or distribute, distribute medication, or distribute beds in a hospital, predict how long somebody's gonna stay hospitalized, all of this, right? This is now where we are now. And so with all of that, now we have been on people who build these systems saying your systems are biased, your systems are not inclusive, your systems are all of this, right? But I think it's a lot to ask of any one entity or any one group of people to be able to capture all of the diversity of life, of people, of ways of being ill, and of ways of being healthy, and ways of living. And so for me, I believe that of course, and this is not just me, lots of people, say this also, but I really believe in the idea that you've got to diversify who's doing the work, right? And we should all just get in there, do the work. We come in with our biases, we come in with our preferences. But what is more important, one, is to acknowledge that we have diverted a little bit from the objective science that was supposed to be machine learning and AI, right? We do not have closed systems like physicists, like nanoscientists, who work in completely clean and sterile environments. We do not have those, right? And so we have to do away with that idea that we are being completely objective and completely scientific in whatever manner that might be, right? And we have got to come to terms with the fact that we embed so much of ourselves in it. And this picture is one of my favorite. I am currently right now sitting in Lesotho. So I'm from Lesotho and I live in Lesotho, and I'm so happy I'm able to still do this work while I'm in Lesotho. And so this is like one of those places I love to go to and just breathe in the air and just be. It's home, and it's great to be home. And it influenced so much of me and the way I do science. So anyways, as I say, from the curators to the people who do ethical AI, and more importantly, I think as we are thinking about health equities, that's, and when we're thinking about for us, and we were thinking about the work we do in ethical AI, one of the biggest thing is to notice that we have data and we employ a machine learning algorithm. The data is there, we have transformed it into some numerical space or some computable space. And once we've got that data, then we build this machine learning algorithm. That too is a series of mathematical steps. So we've got this beautiful math, right? And then this algorithm tells us that you need to give person A something, and you should not give it to person B. We, the people who do ethical AI, have decided that actually that is incorrect, right? So we have got the data and the machinery telling us to go one way. We decide we're not going to go that way because of we think we know better. We think we know where the ground truth is. We're literally saying, no, it shall not be this, it shall be this. And so there is no space where we embed ourselves in this whole process more than in data, when we decide who we're going to look at, where we're going to look, where we're going to focus. And then when we're doing the thing of equity, well, we're deciding that this metric fits better and we are tolerant of this error over this error. Okay, now, besides all of the politics of documentation and all of my thing of why I think documentation is so important, technically, documentation itself, is important in algorithm systems, because it's the thing that allows us to be able to identify harms before, right? It's the thing that allows us to track accountability and to be able to hold entities accountable, the decision makers. It is the thing that allows us to reproduce the work that others have done. And it is the thing that allows us to be able to detect errors as they come. So really, we have got to document in this kind of space. And as I said, we embed so much of ourselves here. And so we've got to say, when this algorithm said this, I wasn't happy with it, and I said it should do this. And I decided that this is the set that is representative for me. This is the data set that is representative for the problem I want to look at. We should do that, because that might not necessarily be true for other people. Okay. So the other thing about transparency, about documentation, is that it allows us to have some transparency into the process, right? And transparency is good because it tells us a little bit about where we're sitting, about the culture under which this work is being done and the aspiration of these people. What is it that they want to do? It helps us share knowledge. It helps us access. This is very important for us in data, right? It's going to tell you what format is the data, how big is it, where is it stored, what are the protection around it, what are the regulations around it, all of these things about data, who we got it from, all of these things about data, right? And the thing we also want to mention is that when we're talking about data documentation, it's got to go beyond the creation of this data set, right? It has got to be like the whole entire process. Of like, we've got to document before what we want to do, and then we've got to document after about like what we got, right? And all and in between as well. And so the other thing that's very important too, especially like now we're coming to terms with this, is that we've got to say what motivated us to do this data set. Why do we think this problem is so important that we're going to divert resources to it? Who is funding this work, right? Who are the clients that we hope to have this to produce this work for? All of this is very, very important, especially in healthcare and health equity, because we do not look at diseases and all problems equally. They are understudied diseases which affect different certain populations, and we've got understudied like segments of the populations. So we've got the problem of underrepresentation of women in a lot of data sets and all of this. So this is the other thing, like what is motivating you to get into this problem, and who is behind, who is supporting you, who is on your team. Okay, I need to minimize my Zoom here because my Zoom is blocking my view. Oh, there is no way to do both of this. Okay, anyway, but as I said, so why is transparency complex in this space, right? Like in doing this kind of like a machine learning work for health, why is this transparency really difficult? And I have to say that here at the beginning, I'm going to start off with just overall, just the process of building these health tools, right? We know that transparency here, this is well documented. It is difficult to map input to output on these large machines, right? Machine learning algorithms will correlate two things that have absolutely no correlation or have some other confounding factor in between them. And it is very difficult to be able to dissect that and figure that out, that this is actually the problem, right? It can be very difficult to reproduce machine learning outputs. Like this is something that is well documented. In fact, in a couple of years back, a whole bunch of these large machine learning conferences, so like NeurIPS and iClear and ICLR and CVPR, these are all like these top conferences for us. They started running this challenge of reproducibility, right? Because people could not reproduce some of the findings from other researchers. Of course, this is something that happens a lot in science, right? Every science discipline after X number of years, people catch on and they're like, whoa, we're having a problem of reproducibility. So we came into ours and we realized that we had this problem a couple of years back. And one of the reasons why it is so difficult to reproduce is because we build and train these systems under such different circumstances, right? The other thing is because they're so massive, we often parallelize them. And when we parallelize them, you've got to come back and aggregate them. And we know that aggregation is not a neutral function. And so, you've got to say exactly how you parallelize, how you aggregated, and all of this. So it can be, all of this. There's also the issue of the order at which you train actually affects the algorithm you're going to get. Yes, we usually say, you shuffle your examples and all of that, but actually machine learning algorithms do have that. They have a point at which they lose some plasticity in learning, and the later examples don't have as much of an effect as the early example. This is very consequential anytime you're going to be importing somebody else's trained algorithm, right? Anytime you're going, because you're then going to then say, I'm going to go on and fine tune, to be aware sometimes that those early examples can be so embedded into that system that it can be, this is one of the reasons why we have difficulties with transfer learning. And anyway, so then the other thing is because they are so large, running through them and auditing them and retraining and all of this is so expensive and is so time consuming. It is not something that can be done all the time. And this, I think, has been like one of the things that, we hear about, like, okay, this is why ChatGPT knows up to X amount of time, right? Because it was trained that time. We can't be training it every day because they're massive. But anyway, so yes, so this is I just cited a couple of works here, which actually, so one of this one about critical learning periods is exactly the thing I'm talking about, that there are periods when you can learn a lot in a machine learning algorithm, and then there are periods when, you lose that plasticity. And these decisions, different engineers are going to train differently. The one about characterizing bias is about all of the work we do afterwards, right? We've got our data, we've got our algorithm, and sometimes we do a post-processing. This was a post-processing where we were compressing algorithms, and we saw that actually when you compress them, you get a whole slew of errors, new errors, and new ways of bias manifests. And all of these, a lot of the time, come from the fact that data sets are not equally distributed, right? Among the attributes are not equally distributed in the data set. Most natural data sets are exactly like this blue curve that I'm showing here. They have that tail end. This is something that we see in many disciplines. Okay. So as I said before also, but like the other reason why transparency is so complicated is the person, is the people who build these systems, right? It's the people who decided what the problem is gonna be, what the data is gonna be, what is the good enough coverage from the problem that I'm looking at, what the ground truth is going to look like. This is something that I know for sure. We used to just take the ground truth as if there really was a ground truth. But we know actually that a ground truth, it is a function of where people live, is a function of resources, it is a function of what's observable, it's a function of the measuring tools that we have, right? That's what the ground truth is. And yet the ground truth is the golden standard we want these machines to emulate, right? And this is also not a necessarily objective thing. Anyway, and then of course, when we decide what solution is good enough, and finally, as I mentioned, whenever we decide that this algorithm is not doing what I need it to be doing, what makes me happy, and I'm going to change it so that it does what makes me happy. Or you can also phrase it as what I believe the ground truth is, or what I believe is just. Okay, so we went on. So this was I got involved into this problem. This project was actually led by Nega, who's still at Google. But as I said, I have this interest generally in documentation. In health, what we wanted to know was, so we want to develop this artifact. We want to develop this health sheet data, right? Which is gonna tell us about who produced and that. And I'm gonna go through some of these features of this. I'm gonna go through some of the features of this health sheet later on. Ooh, should have gotten some water. But anyway, what we wanted, our motivations here, two clients that we wanted to look at. We wanted to look at data consumers and wanted to look at the curators, right? In this process, we want to look at many things. What do you want from this thing? Also, what's going to be the thing that's going to make it really difficult for you to create this tool? So for data consumers, a lot of them are like machine learning researchers, right? They're like people like me who are like, oh, this looks like a great data set. I'm really curious to see what we can do here. And then maybe, you partner up with somebody who's in public health, or you partner up with somebody who's a practicing clinician. But, usually a lot of the time is this, right? You're like curious about this data. But the issue was there's not enough metadata that tells you what's in here. There is no clear description of how the labeling of the data was carried on. And there is no clear description of the inclusion or exclusion criteria. And inclusion and exclusion, I mean, was this, well, all the subjects over 18. So if, this feature about age was not necessarily included, or was this something that was taken at a teaching hospital, or was this a clinical trial? Like were we testing people in a region? What was the inclusion and exclusion criteria here? Because that's going to tell me how generalizable my method is going to be, right? Like where else can I apply my algorithm? Then for data curators, one of the things we were very conscious about, and what people say, and we also know this because we also are in a field that documents a lot, is, we don't want to spend all of our time documenting, right? Somebody wants to go get a data set because they have a problem that is interesting. They want to build a data set that is interesting. And so, a lot of them were like, I don't want to, I don't want to spend my entire time just building this, make it too complicated. The other thing, which is true for not just health data, is that there is not enough incentives for people who create data sets, right? It used to be that we like data creation was something that you could outsource to Mechanical Turk, right? For us, you just get people out there to like label for you, or you just got it passively, right? It was people posting tweets. It was like the data work was not something that has necessarily been looked at as something that is professional, and therefore people should be rewarded for it. And so there was this issue of, if I spend all my time creating beautiful data sets, meaningful data sets, and then somebody else spends their time writing papers and publishing new algorithms, those people are going to get more reward than me. And yet this work is, you need both. But they did think about on the other side that whenever I did create this data set, I had a problem of people always asking me questions, right? Like, how do I get it? What format? How old is it? All of this data, that all of this stuff that was saying, put it on a health sheet, then you can just read it. Then you don't have to read all these many algorithms, all these emails and all of that. And then finally, of course, it's a good idea whenever you have got a curated product, which a data set is, a good data set. I mean, so much of this stuff is built on ImageNet, right? Because it was the one curated and documented data set in machine learning. And so, so for some of the people like, okay, I'll do it because I want a finished product. If I'm going to open source it, then maybe I want something to help me, document it properly. So we talked to people that we regarded as, experts in this field. And a lot of the questions we were asking them were really basic, like, do you use data regularly at your work? What are some of the issues that you think need to be improved? What are some of the things that you're excited about? These kinds of conversations that we're having. And so we had a total of about 21 participants, and we went through fairly in-depth interviews with them. Okay. So what does this thing look like? What does this data sheet thing look like? What's inside it? We start off with just like general description. This is just the basic, what is inside this thing? What does it look like? Just a short summary. How big is it? Has it ever been audited? Where was it used before? Basic 2-3 lines about this. Then we wanted to, the next thing is about keeping track of the version of the data set. How many of them have they changed in between? What was the motivation of going through all of this? And by the way, as I'm going through this, because it's going to be a lot about the process of what we think was important in documenting, please feel free to ask questions as we go through, just to what were you guys thinking here, or why was this even important? But anyway, one of the other things that's really important is every time this data version comes, is this a static? Do you get like a big lump of data, or is it like dynamic every day? It's being updated, just so you know how to build on top of it. So for example, we looked at we built a sample data sheet for the Mimic data set. And so this is, for example, this is what we wrote, about the versioning between Mimic 4 and Mimic 3. So this would be some of the data we thought should be included in this step. Okay. And then the motivation, as I said, right? Like, what purpose, for what purpose was this data set created? Who are the people who were on this team creating this data set? As I said, we are gonna measure what we see, right? And what we see is influenced by where we are, or by who we are in all of this. And so who are the people who make up this team, who funded this project? And more importantly, are there any uses that are discouraged about this data, from this data? This is, of course, very important for health, but also very important overall, now that we are going through all these discussions about the fears and the threats of AI and all of this. But, what is the system made for, and what is encouraged and what is discouraged? Then the data composition, right? You have to tell us, what does this thing contain? Is it images? Is it data points? Like, is it numerical values? Is it a tabular format? Is it, so many, is it geospatial data? There's so many different, I guess you can have geospatial data in the health data set, right? Because people live somewhere. But anyway, so, all of this different types of it. And then, is this a sample of a larger data set, any sensitive attributes, and all of the different things that should be there. So here I've given an example of one of the questions we ask in the data sheet, like what data modality, does each patient consult, each one of this consist of. And so we've got, the answer there, which is a timestamped, and it tells you who put it in. And so you are able to then, decide on the level of trustworthy of this data set. Because we know, data collected doctors, you also can collect data using AI, right? Like you can infer, you can, you've got now algorithms which will diagnose you. Or you can, all of this, but there's a lot that you can infer, right? You can infer other features that are not necessarily about the disease. You can infer, they say you can infer age, you can infer gender. There's lots of studies which we have kicked out, those who say like we can infer sexuality of these things that, there's like stuff that may be, and then there's stuff that's just really bad science. Anyway, moving on. Then, of course, there's the thing about the devices on which this data is collected from. Remember, I talked about the issue of reproducibility. Devices are one of the reasons why, we run into issues of reproducibility, both the devices of data collection and the device of, of like where we were training, or devices that you use while you were cleaning your data, the devices where your data is stored so that you can build your pipeline accordingly, and all of these things. So devices to collect and store and all of that. Then generalization and reproducibility, as I said, where is the sample built from? Who's in the sample? Who's not in the sample? How was this data collected? Things like a view of a chest X-ray image. I had no idea this was important, of course, but apparently it is. So this is important to document, So like when we're talking to some of the clinicians, they were like, this kind of information is important to know, right? They were like, if I know that this data is collected from this specific hospital, or this specific university hospital, I know what to expect. So this sort of stuff should be included in this. And we're like, oh, well, good to know. We didn't know that. Or like, if it was collected from this lab, I know what to expect. So all of this sort of stuff, like where can I use this data, right? If it's collected in the US, can I apply it in the UK? Can I apply it in South Africa and all of these other spaces? Can I apply it in Japan? And so, it goes to the idea of how generalizable is this? Can I train a model and then deploy it in funds with this data set? And then, of course, the thing of demographic information. Did we collect any demographic information? More importantly, why, right? Like, is this medically relevant? Why did we? And then, of course, how? Was it self-reported? Was this inferred from people posting online? How did we get this data? Is it protected by law, right? Yeah, you even allowed to do this? Are we allowed to do anything with it, right? Because sometimes you're not even allowed to process demographic data. And also this is like, and on and on and on and on. And then, of course, labeling and subjectivity of labels, right? We have been going through a whole thing in machine learning about labeling, which has been who should label, right? And because labeling is about ground truth. So who should label this? And a lot of the time we have gotten into places where we will say, okay, we're going to get multiple people label, and then we'll have like an average. And as I said, an averaging or summarization function is never neutral, right? So let's say you pick a maximum vote, right? And it's going to look totally different from, let's say, another kind of averaging. But, so you should say, I have 5 people say, this looks to me like, some form of skin cancer. And I decided that, I'm going to believe 3 out of the 5 or something like that. So some kind of like the max vote. And then, of course, this is, aside of a bit of the ethics that we have also been going through is, where people compensated for their time, right? As I said, historically, it's been that data work has not gotten the respect as much as like model building. And so people have not like, when you build models, right, you go work at these companies and get paid a lot of money, and that's great and fun, right? But like when you're a data labeler, right, you get hired by some third level company, right? Like the company that needs the data is up here, and then it hires this and it hires this and it hires this. And by the time it gets to you, it's $2 an hour, something like that, right? And so, were people properly compensated for their work, right? And then this is really funny about medical data, which is that quite often, even here in Mimic, quite often there is no real target label, right? Like you just collect clinical data. And then like for us in machine learning, once you're going to do that, like we want to know what's the target, right? What's the thing we're going to learn? What's the why, right? Because everything else is going to be the X, right? And then what's the why? What's the thing that we're going to predict? The upside is obviously any feature can be a Y, right? You can change it around to being that. But then I think sometimes, then you lose this idea of like, oh, this is the label, right? Because there's something important about the label, which is that the label says, if I observe this, then the truth is this, right? And so if you don't have a designated label, then yeah, anyway. So so you can ask a whole bunch of questions, like, did you directly ask the individuals, or did you get this secondary at either a lab or a hospital or that, right? Then inclusion and accessibility, we've got issues of land inclusion and other forms of inclusion, but then also, of course, as I said, in health, you have to think about who actually is in the study, who who is visible to the data collectors, who was visible at that time, who could they reach given their resources, both financial and time and all of that, all of this. So, who and how accessible then is this data set? The users of all of this. And I think one of the biggest things for the users is, one, has it ever been used for something else before? And what did that look like? And then I think the second thing then is, what should it not be used for? And of course, we summarized a little bit about that in the general, right? Because the general is gonna say this data set is for X, it should be used this way. And so now we can go into the details of exactly who and who should not. Of course, some other things are like, it shouldn't be used for like commercial entities or it shouldn't be used to solve this kind of problem. Also, the other thing that's important is it shouldn't be dissected along these axes, right? Because we don't think that's good, and that study should not be looked at. And then finally, the distribution and maintenance of it. How is it? How are we going to keep updating it? It's of course linked to the question of versioning. Who's going to maintain it? Who's going to make sure it's well protected? It is health data after all. Where is it sitting? What are the laws and regulation of it crossing boundary, country borders, and all of these other questions that we might have. There's a whole list of them. Things like export controls, and then of course, like product for access, right? Exactly how do I do? I just send you an email and then you let me in, or do I have to be a so-and-so and then you let me have this data set, etc., etc. Okay. And so, finally, in conclusion, what we hope to do, for me, it was a big team. And we all had different reasons for going in, right? For me, I thought this would be a great artifact to start to have conversations. I think this is an effect that should and will keep evolving. If it's going to be useful, it should keep evolving. I don't know if it should get longer or it should get shorter. Maybe for some application, it should be longer. And for some, it should just be shorter, and so on. I don't know. But what we wanted to do was to create this thing that at a glance, give you an idea of what's in, what you should worry about, what you should try to improve upon. And then finally, it's always really interesting to see what people were thinking at a certain time. I think especially now, even in machine learning, I started doing this, properly around 2010. And in that 10 years, so much has changed. It would be quite illuminating. I know there are some things that I'm quite, oh yeah, we shouldn't have studied that. Oh, this is not. But that documentation, and unfortunately for some of us, the papers exist. And so that documentation exists. But, this kind of thing to see what we're thinking, because as I said, part of the documentation captures the culture under which we're doing this work right now, because it illuminates what we think is important to jot down, right? And so, yeah, that's the work, documentation, and all the fun of it. Thank you all for listening. And I'll take questions.